Hello, everyone, and welcome to today's webinar. One hospital took its exclusive breastfeeding rate from 50% to 83%. You can too, with Dr. Sino George. Before we get started, I would like to go over a few items so you know how to participate in today's event. You've joined the presentation listening using your computer's speaker system by default. If you would prefer to join over the telephone, just select phone call in the audio pane and the dial-in information will be displayed. You will have the opportunity to submit text questions to today's presenter by typing your questions into the questions pane of the control panel. You may send in your questions at any time during the presentation. We will collect these and address them during the Q&A session at the end of today's presentation. Today's webinar is being recorded and will be available to view at Medill University in the coming weeks. Please remember to download the handouts from today's webinar during the live session. You'll see the handouts in the panel of your go-to screen. I would now like to introduce Dr. Sino George. Dr. George, DNP, APRN, RNC-OB, WHNP, BC, recently retired as a clinical nurse specialist after 21 years of helping new and expectant parents as they navigate the journey of expanding their families. Hailing from Atlanta, Georgia, Dr. George says she's become involved with healthcare because from a very young age, she had a passion for helping others and decided to pursue nursing as her profession. Prior to retiring, Sino worked as a She worked as part of a large health system in Georgia where her hospital was designated as baby-friendly in early 2015. During her time as part of this health system, she strove to change practice at her facility and implement evidence-based quality improvement projects to benefit both patients and clinical staff. Quote, in my APRN role, I brought evidence-based practice to bedside nurses. She goes on to say, if there is no current evidence, we created it through research. Our breastfeeding exclusivity rates were going the wrong direction, so I implemented the role of neonatal assessment nurse in labor and delivery for immediate skin-to-skin care and was thus able to increase breastfeeding exclusivity. Take it away, Dr. George.
Hello, good afternoon. This is Sino George. So good to speak to all of you about our journey of improving breastfeeding exclusivity by increasing skin-to-skin contact of newborns. Next slide. So today's objectives are, I have three objectives. One is to address strategies to improve breastfeeding exclusivity by increasing skin-to-skin care immediately after delivery. Second, to implement the role of a dedicated neonatal assessment nurse whose primary responsibility is the newborn. And then the third objective is to train mother-baby NICU RNs in the role of neonatal assessment nurse to transition the newborn. Next slide, please. Human milk provided by direct breastfeeding is the biologically normal way to feed an infant. There are very few true contraindications to breastfeeding, and scientific evidence overwhelmingly indicate that it is nutritionally superior. The benefits of breastfeeding are recognized throughout the world. Breastfeeding benefits not only the mother and her infant, but also society as a whole, when taking into consideration the decrease in illness and associated costs. Some of the benefits for the babies are it is easily digestible, it is loaded with immunoglobulins, breastfeed babies are at low risk for ear infections, necrotizing enterocolitis, sudden infant death syndrome, type 1 and 2 diabetes, childhood cancers, obesity, etc. There are also many benefits to the mothers too. Some of the benefits are they are at low risk for postpartum hemorrhage, postpartum depression, low risk for breast, uterine, endometrial, and endometrial and ovarian cancers. Next slide, please. So looking at the background, the American Academy of Pediatrics, the World Health Organization, and US Healthy People Initiatives have recommended that mothers breastfeed their newborns exclusively for the first 6 months of their life. Exclusive breastfeeding means that the infant receives only breast milk, no other liquids or solids are given. Despite literature and national standards, there continues to be an abundance of new mothers who either chooses formula feeding or discontinue breastfeeding at an early age. The most current breastfeeding data demonstrated a national average of 83.2% of babies born in 2015 initiated breastfeeding, 57.6% breastfed for 6 months, and 35.9% continued breastfeeding for 1 year. So this is the latest data from CDC, and CDC a little bit behind on data. Next slide, please. So looking at Georgia, that's where our practice is. So I looked at the state of Georgia. The breastfeeding exclusivity rate for the state of Georgia at 3 months and 6 months of infant age is 43.9% and 22.1% respectively. According to the American Academy of Pediatrics research, 3 out of 4 Georgian mothers instantly started breastfeeding, and roughly only 19% sustained for 6 months. Therefore, the breastfeeding duration in Georgia needs serious consideration. Next slide, please. The study hospital where I practiced, breastfeeding exclusivity rates were in the range of 50 to 60%. And our target as a baby-friendly hospital was set at 80% at discharge from the hospital. The practice of skin-to-skin contact after vaginal birth is at an average of 49% of all the deliveries. And the practice of skin-to-skin contact after cesarean delivery is at an average of 33%. Both have trended downward for us. Next slide, please. So looking at what happened and why this trend downward, we did anticipate and looked at some problems, and there was some unanticipated growth in the year of 2018 to 2020 in the study hospital, where delivery numbers increased from 4,000 a year to 6,000 a year. The data on initiation and duration of skin-to-skin care immediately after delivery was trending downward. Hence, the breastfeeding exclusivity rate was stagnant at around 50 to 60%. And looking at staffing, current staffing ratios and clinical practices are not up to the guidelines of the national recommendations set up by APRN to support skin-to-skin care. APRN is the National Association of Women's Health, Obstetrics and Neonatal Nursing. Next slide, please. So this issue was taken into consideration, and we looked at it and put it into a PICO statement because we were going to deal with it as a quality improvement project. So the primary PICO question for this project was in primiparous and multiparous patients immediately post-vaginal and cesarean deliveries, does the implementation of a newborn assessment nurse, which we call NAN, as compared to the existing practice of no NAN, increase skin-to-skin contact and thus improve exclusive breastfeeding rates by 20% from birth to the time of discharge. And we also had a secondary PICO, which is for RNs participating in the NAN program, does the implementation of a competency program through education and validation as compared to the current orientation program improve nurses' knowledge in improving skin-to-skin care and transition care of the newborn in the delivery unit. Next slide, please. So as any one who's working on a project, we do know that you have to review literature. So we did some extensive review of literature. the effects of skin-to-skin care on breastfeeding exclusivity. We looked at a few studies. Study done by Kadif Sade in 2017. This was a randomized control trial looking at breastfeeding in skin-to-skin care group, which was at 40.4% versus 20%. So with a p-value of 0.05. Linares in 2017 did an observational study. Mothers with vaginal delivery practiced early skin-to-skin care, 86% versus 15% of those with cesarean, with a p-value of 0.001. Koopman and group in 2016 did a qualitative study on early skin-to-skin care and provided a better understanding of clinician perspective. Crenshaw in 2019, they did a quasi-experimental study. Women who began skin-to-skin care during surgery were more satisfied with experience, with a p-value of 0.015, and had a salivary cortisol level of and the p-value was 0.003. Cusco and group in 2019 did a meta-analysis of randomized control trials and compared to control group, those in skin-to-skin group were 30% more likely to exclusively breastfeed. Next slide, please. So although skin-to-skin care is a simple intervention, there are several facilitating factors and barriers identified. And some of these studies we looked at: Abdul Ghani in 2019, Alan Cherry in 2018, and Ferrarello in 2014 conducted qualitative studies and documented barriers like mothers not interested to do skin-to-skin care, absence of policies to support skin-to-skin care, staffing issues, time constraints, difficulty in decoding eligibility for skin-to-skin care, interference with clinical routines, visitors in the room, others wanting to hold the baby, and knowledge deficit of mothers. Next slide, please. We also looked at some quality improvement project, which was implemented to improve skin-to-skin care. Brady group in 2014 documented 43% of mothers after cesarean delivery experienced skin-to-skin care in the OR operating room, and exclusive breastfeeding increased from 30 to 63% in 4 months. Muhammad and group in 2018 achieved and sustained exclusive breastfeeding in first 24 hours of life in more than 90% of enrolled infants. CVAC, K, and Williamson in 2013 implemented a contemporary role created to continuously provide transitional care for eligible newborns without mother and baby separation. They incorporated newborn assessment nurse, a NAN role, into the care of the newborn at bedside. The NAN role in the labor and delivery recovery facilitated an extended help of having a dedicated nurse to provide newborn care in situations when the newborn transition time needs further assessments. Next slide, please. American Breastfeeding Medicine Clinical Protocol, International Lactation Consultant Association Clinical Guidelines, and Baby-Friendly Hospital Initiative Guidelines. All of these clinical guidelines emphasize that all mothers should be given their infants to hold with uninterrupted and continuous skin-to-skin contact immediately after birth and until the completion of the first feeding. If there are documented medically justifiable reason, then skin-to-skin contact is delayed until the newborn and mother are stable. Next slide, please. So since this is an evidence-based project, our purpose of the project was to improve skin-to-skin care for all eligible newborns immediately after vaginal and cesarean deliveries, and thus able to increase breastfeeding exclusivity at discharge. Next slide, please. as I said from the beginning, this was a quality improvement project using evidence-based guidelines to implement the new role of the newborn assessment nurse immediately after delivery. The project manager created a pre-test and a post-test to measure the knowledge of the NAN team. After recruitment, a 2-hour didactic education was offered to the NAN group, and competency was validated as they spent 2 8-hour days in labor and delivery unit. Approval to conduct this project was obtained from the IRB of University of Alabama, Huntsville, and Emory University Hospital, Midtown, where the project was implemented. Consent was also obtained from the participants who volunteered for this project, and these are mainly from the nurses. Next slide, please. So this project was implemented in the Labor and Delivery Department of Women's Health Division of Emory University Hospital, Midtown, which is part of a large health system. Women's Health Division consists of maternity registration. We have 18 labor delivery recovery beds, 5 operating rooms, 4-bed post-anesthesia care unit, PACU, 10 triage beds, 11 high-risk antepartum/postpartum beds, 51 postpartum beds, and a level 3 NICU with 48 beds. Emory University Hospital became a baby-friendly designated hospital in 2015 and was redesignated in 2020, and they are preparing for the next redesignation in 2025. So the participants for this evidence, next slide, please. The participants for this evidence-based project were registered nurses from the Women's Health Division who were interested in the role of the NAN. These were male or female RNs age 19 or older and cared for the mother-infant diet, working either full-time, part-time, or in PRN capacity. Recruited 25 RNs into this role, which was about 25% of all RNs, so that there would be coverage 24/7, both day and night shifts. Next slide, please. So the patient population, we have the inclusion criteria here. Inclusion criteria for patient population were primiparous and multiparous stable mothers after vaginal and cesarean deliveries, and excluded unstable mothers and their newborns. Next slide, please. We will have the details of mothers and newborns on the next slide. So on this slide, you will see inclusion criteria for mothers, as I said, primiparous and multiparous mothers, stable mothers with stable vital signs, and they are alert and oriented. Both are after post-vaginal and cesarean deliveries, and of course, they have given birth to a live baby. For the inclusion criteria for the newborns, these are stable newborns, and those included full-term babies from 37 to 41 weeks, as well as late preterm babies from 35 to 36 and 6-7 weeks. So the exclusion criteria for mothers with unstable vital signs, if they had received general anesthesia, they were excluded. And if also they had any complication of surgery. And we also excluded postpartum hemorrhage if the blood greater than 1,000 ml. And also if the mothers got transferred to the intensive care unit for complications after delivery. Newborns exclusion criteria were newborns born with congenital anomalies, of course, preterm babies less than 34 weeks of gestation, newborns with UPGAR scores less than 7 at 1 minute and less than 8 at 5 minutes, newborns requiring immediate transfer to NICU. So all these newborns were excluded from the study. Next slide, please. So looking at the interventions, the project manager recruited interested RNs into the NAN role after obtaining their consent. Since this was a study, we had to get the consent. NAN received additional training consisting of didactic education of 2 hours using a PowerPoint and a video presentation, followed by clinical competency validation. So this clinical competency validation was done in the labor and delivery unit by the project manager. Didactic education included the benefits of skin-to-skin care, safety while doing skin-to-skin care, and the benefits of exclusive breastfeeding. Skills were validated by the project manager through one-on-one observation, hands-on practice, as well as teach-back method. Also, just to add on, all RNs who are recruited to Women's Health Division, they do receive breastfeeding training within the 6 months of their hiring. So that is required for all RNs. So this education was in addition to that education they obtained. Next slide, please. So the intervention here, at the beginning of the shift throughout the day, the NAN reviewed the labor and delivery census board and had an understanding of patients who were imminent for delivery and reviewed their charts in preparation to assist the patients. NAN was in communication with the primary RN and the charge RN to understand the progress of the patient. And NAN was present at all deliveries and provided care at the bedside so that the mother and the baby were not separated. NAN assisted with skin-to-skin care, breastfeeding, and transitional care of the newborns. If the mom chose to formula feed, then of course skin-to-skin care was implemented even if they were not breastfeeding. NAN also documented the initiation and duration of skin-to-skin care and initiation and duration of breastfeeding in the electronic health record. She obtained vital signs of the newborn, made sure that the side rails were up when the mother was alert and oriented with stable vital signs. NAN stayed with the mother while doing skin-to-skin care if significant other was not present. Next slide, please. Data collection. Now, skin-to-skin care initiation and duration after vaginal cesarean delivery data was collected, reviewing the electronic health record, and chart audits conducted monthly throughout the project. The RN documented the data point of exclusive breastfeeding electronically in the EHR, who also documented infants' intake as either the minutes at breast or the amount of formula consumed. A run chart tracked the progress of the project over time. Demographic data like age, ethnicity was currently collected in the inpatient EHR. Biological data such as gravida, para, the desired feeding method, whether it is breast or formula, the type of delivery, date, and time of first feed were entered by the RN in the EHR database. The data was collected monthly during the duration of the project. Next slide, please. So data analysis. For the NAN test scores, descriptive statistics were obtained for all measures and demographics. Correlation between education level, years of experience, and pre-test scores were performed using the non-parametric Spearman's Rho correlation due to the ordinal nature of the data. A paired t-test was performed to analyze test scores from pre to post-test training. Given the small sample size and the ordinal nature of the data, pre-test scores were only ranged from 50 to 100. The non-parametric paired Wilcoxon-Rankin test was also performed, which additionally provided a summary of the number of nurses who improved their test scores, positive ranks, and stayed the same, which tied or got worse, negative ranks. For breastfeeding exclusivity, descriptive statistics, For breastfeeding exclusivity, descriptive statistics were obtained for all measures and demographics for both the mother and infant. Demographics and skin-to-skin and breastfeeding measures were described for the overall sample and by the breastfeeding exclusivity groups, yes versus no. Comparison tests between the breastfeeding exclusivity yes versus no was performed using two independent group t-tests for normally distributed measures, two independent group Mann-Whitney test for non-normal or skewed measures, and chi-square tests for independence for categorical measures. For small cell counts, some categories were merged prior to chi-square test being performed, and the analysis was performed using a SPSS version 27. Sorry about the details of the test. Next slide, please. For the NAN test scores, so now we're looking at the results. All 25 nurses who compared the NAN training were female. The majority had associate degrees, which are N of 20, which is 80%, with 8% having a bachelor degree and 12% having a master's degree. Pre-test scores ranged from 50 to 100 and had an average test score of 78 with a standard deviation of 13.23. However, the pre-test scores were not significantly associated with either education level nor years of experience. Post-test scores range from 80 to 100 with an average of 93.24 with a standard deviation of 7.48. Every nurse either stayed the same or improved their test score. Improvement ranged from 0 to 40 percentage points, with 72% improving their test score, 7 or 28% staying the same, and 0 getting worse. So these improvements were statistically significant with a p-value of less than 0.001. Next slide, please. So this is the run chart we used. Breastfeeding exclusivity data was collected for 150 mothers. A run chart was utilized to track data over time to measure skin-to-skin care after vaginal and cesarean delivery and breastfeeding exclusivity. The process measure of skin-to-skin immediately after vaginal delivery increased from 49 to 84%, and cesarean delivery from 33 to 61%. The outcome measure of breastfeeding exclusivity at the time of discharge from the hospital increased from 50 to 60% to 92%. Next slide, please. So sustainability. So this data was shared with the leadership team of Women's Health Services and the NAN team, the Neonatal Assessment Nursing team. The Baby Friendly Task Force team will continue to monitor the data as part of the Baby Friendly requirement. See, the Director of Women's Health Services has plans to make the NAN role a permanent part of the labor and delivery unit in the future, and which she has already implemented that. The mother-baby manager has made this role a part of all new hires, and the training and competency assessment will be part of onboarding. The project managers submitted and published a manuscript in the Journal of Nursing for Women's Health according to the journal author guideline requirements. The target audience for nursing for women's health are nurses, midwives, advanced practice nurses, other providers, and related professionals. Therefore, articles have clear implications for practice, research, and/or policy, and continue to and contribute to the evidence base for the provision and development of care beyond the study setting. Next slide, please. This project also had some barriers. This project was planned and implemented during a pandemic. Health systems across the globe have faced unprecedented strain and uncertainty during the coronavirus pandemic. Although there were staffing challenges, it became very apparent during the new variant Omicron of COVID-19. Many staff members contracted the virus, even though vaccination was mandatory for healthcare workers. The role of the NAN was originally intended to be 24/7, but staffing this role on all shift is still a challenge due to the increased volume of deliveries and staffing shortage. The feasibility of implementing this role may vary from hospital to hospital depending upon their staffing level. However, it is a vital tool in the maintenance of baby-friendly health, breastfeeding health initiative step 4, which is skin-to-skin care for all eligible newborns immediately after birth. Next slide, please. So, implications for nursing practice. Exclusively breastfed infants have far more immediate and long-term health benefits compared to formula-fed infants. NAN provided transitional care at bedside without separating mom and baby. NAN provided dedicated and safe care to the newborn immediately after birth. And this was an innovative role without hiring new staff. It also provided evidence-based care with great neonatal and maternal outcomes. And breastfeeding is one of the smartest investments to build children's future and prosperity. So in conclusion, next slide, please. In conclusion, breastfeeding exclusivity data was collected for 150 mothers. The process measure of skin-to-skin increased from 49 to 84%, and cesarean delivery from 33 to 61%. The outcome measure of breastfeeding exclusivity increased from 50 to 60% to 92%. Statistically significant difference in the pre-test and post-test scores of the NAN, which is with a p-value of 0.001. So by improving skin-to-skin care immediately after delivery, breastfeeding exclusivity rates did increase more than 20%. Having a competency-based didactic education improved the knowledge level of the NAN team. The benefits of skin-to-skin, even in today's current climate of the pandemic, outweigh the risk of possible transmission to the neonate, and immediate skin-to-skin care continues to be recommended by World Health Organization. Therefore, initiative to skin-to-skin care immediately after delivery remain imperative to the care of the maternal newborn diet during this global pandemic. Though I did not measure or collect data on staff satisfaction, there has been an improvement in collaboration and cohesion between the labor and delivery, mother-baby, and NICU department staff since the implementation of the NAN role, as per the report of the labor and delivery manager. Before the project, there was a feeling of territoriality among nursing staff, which decreased morale and now transitioned more to an open communication and collaboration among sister units. And this culture change was very apparent, and it was, the leadership team was very happy about this change also. I think that is all the slides I have, and I have a couple of slides. The next 2 slides, please, are references. And at this point, I will stop my presentation here, and I will wait for questions. Thank you so much.
Oh, sorry about that. Perfect, Dr. George. And let me say again, I apologize for mispronouncing your first name yet again.
No problem.
Thank you. All right, the very first question, and please do continue to send in your questions to the questions pane of the control panel. The first question is, when the bottom line is often the determining factor, how can we justify adding a new position such as the NAN? Do you still employ NANs? Are they on staff 24/7?
Great question. Again, as in my introduction, it was mentioned that I recently retired from nursing, so just enjoying retirement life, but I do keep in touch with the hospital where I practiced and implemented this. They do have this role ongoing, and the biggest point for this was not a newly hired position. We used the same nurses who were hired for the labor and delivery mother baby NICU units and gave them the extra training, and that's how this was able to be implemented, because every hospital has challenges with staffing and of course hiring. So my selling point was this is not a additional hiring. It was just giving more information to the nurses who was already hired. Did I
Perfect.
answer that question?
I believe you did.
Okay.
The next question.
Yeah.
Who provided this newborn care prior to the implementation of the NAN? Was it the L&D nurse caring for both the mother and the newborn? Or did the newborn, oops, sorry, my question jumped, forgive me. Or did the newborn go to the newborn nursery?
Great question. So yes, the labor and delivery nurse was the one who cared for the mom and the baby the first immediately after delivery. And so this was a challenge. As you all can see, we do about 6,000, over 6,000 deliveries here. It's a very busy unit. So the nurse was managing two patients, so the mom and the baby, and both needed full care, right? So that's why this role was implemented. So the hospital do not have a newborn nursery, so mom and baby stayed at bedside until they are transferred to the mother baby unit. So this was a challenge for us, and that's why our numbers were going down on our skin to skin, because taking care of two patients at the same time is a challenge. And again, our guidelines do require us to have two nurses in a labor and delivery unit where mom needs a nurse and the baby needs a nurse.
Perfect.
Did that answer that question, or any further questions? That
the next question is, what about babies 34.0 to 34.6? Were they included or excluded? The previous slide doesn't discuss this age group.
Yes, good observation. So the late preterm babies are, are from 34.6 to, that 1 week of late preterm babies. In our hospital, in our NICU unit, those babies are transferred to NICU for the first 12 hours of their life, because that age group showed a little bit of difficulty in transition. So skin to skin is provided if that baby was stable, but those babies needed a little bit of extra care. So they went to the NICU for the first 12 hours. And as long as they kept their temperature and had no feeding issues, then they got transferred to mother baby to be with their mom. For the first 12 hours, they are in the NICU, and that's why those babies were excluded from our study.
Perfect, thank you. The next question, how many NAN nurses per shift? Was there lactation consultant support? I'm not sure.
Yes. Yeah, so the plan was to have two, 24/7 coverage. Depending on the number of delivery, either one or two, that can go from room to room and do the NAN transition of the babies. Our plan was to have two every shift, two daytime and two nighttime. But of course, with staffing shortage, and as I said, this was during a pandemic, and the staffing shortage still continues there. So at least one, but the plan was to have two, at least one for the full 12-hour shift, and then night shift too. And if we had enough nurses, then there would be two on every shift. And we do have lactation consultant on staff. We have, as I said, with the number of deliveries and the baby-friendly criteria, we are staffed well with lactation consultants. So we have 3 consultants during daytime, and then 2, one overlaps into the evening shift, and then a 8-hour shift, and then we also have one during the night shift. So we do have lactation coverage 24/7.
Perfect.
We were lucky. Thank you.
So many questions coming in too. The
Oh,
next
good,
question,
good.
and forgive me, some of these questions may overlap. So
Sure,
if I
no,
mention a question that you've already addressed, you can feel free to mention that.
sure.
The next question is, did your team use donor breast milk for infants needing supplementation?
Great question. We do use donor breast milk, mainly in the NICU. That's what we were using. And as I was leaving, we did implement donor breast milk for our late preterm and the moms who have difficulties. We were just implementing that. It is not fully implemented as of it probably is now. I can't give you the latest data, but we do use donor milk for our babies. We do.
Perfect. What was your pre and post test questions for the NAN nurses?
Those are basically using, looking at skin to skin care and knowledge and those kind of questions. I'm not able to give you all the questions right now, but it is available. If I can provide those questions back, if anybody is interested, I can send those questions. Or if you are, this study is published in the Nursing for Women's Health Journal, and that publication has a attachment to it with the questions and also the competency assessment form. All that is available on that attachment. But if not, I can always provide that through
Medela?
Medela, yes.
Perfect. Perfect. The next question, how can we find out what specific education you used for the NAN? That might be a similar question.
Yeah. So as I said, because we are baby-friendly hospital, we do have very the first 6 months of our hiring and onboarding, we do have education. We use the step 2 education that is coming out of Australia and is very comprehensive education. So that is required of all nurses in women's health. So from that, we for the NAN training, we took some of the information as well as really focused on skin to skin care, the importance, the benefits. Those are some of the things we really focused on, and then competency was assessed on that.
Okay, perfect. And we've got a lot of questions, so hopefully you're still okay.
Oh yeah, absolutely. I would like to. Yeah.
Perfect. The next question, we already have a NAN in place. They do help mom breastfeed for the first time, however. We often see formula being given shortly after. Any suggestions how to curb formula being given? This is a fallout before lactation can even get a chance to work with them.
Yeah. Again, we also have similar issues in our hospital. It is a challenge, especially our postpartum nurses who have at least 3 or 4 couplets to take care of. So they struggle with that. And that's why one of the things before I left, we wanted to make sure we have lactation coverage 24/7, and we were able to implement that. So that definitely helped. And all our nurses are trained to help with breastfeeding. So our lactation consultants only came in when they are called because they do not see all patients, because they do cover our NICU also, which those moms need a lot of help. So our nurses are well trained to take care of, breastfeeding and challenges. But again, when they are struggling, that's why the lactation nurses are there 24/7 for us. So that was one of the big things for us to have that 24/7 lactation coverage, which helped us with that challenge. But I'm going to be honest, it is not always perfect. That 3 a.m. onwards to 3 a.m. to 6 a.m. or 8 a.m. in the morning, that's the very bad timing for moms who are tired and they are ready to give up. But as I said, that's when we can go in as nurses. We go in and help those moms to, do hand expression and help them or whatever way we can. But that is again, that is a challenge for us too.
Perfect. Is the NAN only for immediate skin to skin after delivery and not mother baby unit?
So mother baby unit, the nurses are, they have 3 to 4. Those are more stable babies, so they should continue skin to skin. But our challenge was in the labor and delivery area, and that's why this role was implemented in the labor and delivery area, because of the nurses running from, not able to take care of mom and baby at the same time. So that was a big challenge for us. And we are a tertiary care hospital where we do have very complicated moms who come in from all over the state of Georgia for delivery there. So we do have a very pretty sick population. So we didn't want the primary RN to be focused on a sick mother and a sick baby, if both are sick or if they are not unstable. So that's why this role really helped implemented in L&D to get that initial skin to skin. And then, and the expectation was that they continued skin to skin in postpartum too.
Perfect. And we still have many questions, so bear with us.
No problem. No problem.
Wonderful presentation. We are working on a similar project at our hospital called Breastfeeding Crew. I'm curious if the NAN is a role they do in addition to their other nursing role. Is there pay or incentive for participation?
Great question. Sounds like a similar role, but our NAN is it is. So as I said, there were 25 nurses and who got trained in the NAN role, so they're rotated. So if they are working 12-hour shift 3 days a week, 2 days they may be labor and delivery nurse or mother baby nurse to do their regular job, and then that one extra day, one of the 3 days they will be assigned as the NAN role. So they're rotated. So it was like you're stuck with one role. They're rotated. They are all mother baby labor and delivery NICU nurses. They did their regular job, but one of those days of their working, one of them got turned into a NAN role. So that's how we use them. So this way they won't be, just stuck with doing one role. What was the second part of that question? I kind of forgot.
Oh my goodness.
Sorry.
Bear with me. No, don't be sorry. I just have to go back to it. Forgive me because I have to backtrack to that.
No problem. My memory didn't keep the second part.
I think we need to move on. Let me see if I can still find that question.
No
I apologize.
Yeah.
Let's move on to the next one. I'll see if I can find that one.
Okay.
What was your time frame for skin to skin, just immediately or within 5 minutes? If NICU is called for a high risk delivery, the baby goes to the warmer after 1 minute delayed cord clamping. Then after 5 minutes, we do skin to skin. Does this still count in your numbers?
So our policy was immediate skin to skin. So for a vaginal delivery, the baby get delivered, and right there, the baby is put on mom's. We have warm blankets on the belly and kept on the belly, and then cord is clamped because we do use practice delayed cord clamping. So the cord is clamped, and then the baby is dried and moved up to the chest where she will do skin to skin. So for vaginal deliveries, it is immediate skin to skin, and that baby until the first feeding is completed, we do not move the baby out of mom's chest unless there is a need for it. For example, the baby is not looking good or the mom is not feeling well. The baby stayed on, so we do not keep that 5 minutes. It is immediate skin to skin. Now for C-section babies, again, the baby gets delivered and cord is clamped in the field, and the baby taken to, for a minute, taken to the receiving nurse with the warmer and get immediately dried and brought in within a minute or two to the mom to do skin to skin in the OR. So with the C-section, we have a little bit of a little delay, a minute delay, but vaginal, it is just immediately after with delivery. So that, and then everything like, vitamin K, all the stuff that we do to the baby, banding and weighing, all that happens after the breastfeeding is completed or skin to skin is complete or mom is tired.
Okay, perfect. And then backtracking to the last question about the NAN role being an additional nurse or the second part of that question was, is there any pay or incentive for participation?
Correct. Which again, I have put in for that and asked the labor and delivery, managers, but I am not sure if that is already implemented now or if they get an increase in pay. I am not sure about that current practice right now. So sorry,
Okay.
I do not know. I wish they should be getting some incentive.
Perfect. The next question. My hospital is implementing this role right now. I'm a mother-baby nurse, and our OB/GYNs are notoriously not supportive of skin-to-skin and breastfeeding after delivery, as they want the baby's weight immediately for their charting. How do we advocate for this when the OBs
Wow.
have so much more power than we do?
Right. Oh, that is a great question and a great challenge for many hospitals. Fortunately, when I'm the project manager for the baby friendly journey for our hospital, so the first and foremost thing I did was get my OBs on my side for this. So that was a big challenge for me initially, but fortunately, I had some OB obstetrics champions in this role who was very good with advocating. And we, as a baby friendly hospital, all staff are required to have education, and the physicians also had education, and we had to maintain that education as part of staying baby friendly. So we have to maintain that. So that was one of our benefits, was to get the physicians on our side. I mean, we do have some challenges with certain people, but majority of our physicians were on our side when we implemented this. So very important to get the leadership team on your side, as well as the, I would say, go to your OB chief of staff or neonatal chief of staff, and then have them address this. More power to them than the nurses going to it. Of course, keep nursing with you so that they will support you as a nurse going to these meetings. And that was one of my big challenges. And my saving grace was our hospital is a teaching hospital, and we are research-based hospital, lots of evidence-based practice. So I was able to sell it as the best guidelines for our babies, and this is the best thing. So that really helped. And of course, I'm not saying it's 100% perfect all the time. We do have physicians. So having the chief on my side, if their numbers, and I was able to pull numbers and show how many of a certain physician who falls out, not doing skin to skin, then to show their chief and say, hey, this is our practice in this hospital, and she's not following, or he's not following this, and they were able to address that with their colleagues. Peer-to-peer evaluation was also performed on these people. So yeah, it is a lot of culture change. It is a lot of headache, getting everybody on your side, but it is worth the fight.
Perfect. And you're getting so many compliments from people saying what a wonderful presentation, how amazing this
Thank you
is, just
so
so you
much.
know.
Thank you so much.
The next question, how could doulas and NAN work together to support the client for lactation, feeding, and skin to skin? And how could doulas and our clients request NAN or advocate in a hospital setting?
Oh, I think that is a great question and a great thing to start. We do have doulas where we practice, not a whole lot, a few, and they come in basically to help moms. But I think if we have some good training for the doulas with skin to skin and helping moms breastfeed, I think that is a win-win situation. I think that is a great way to go and advocate for the doulas, and absolutely they can work tandem and work hand in hand. And I think it is a win-win situation, not only for the moms, for the newborns. For me, it is the babies who really get the benefits of skin to skin. So go for it. Get the doulas on your side. That's my agenda.
That's your plan.
Yeah.
Okay. How do we keep exclusively going after the initial? I'm sorry. How do we keep exclusively going after the? Oh, forgive me. My screen just jumped on me again. How do we keep exclusively going after the initial stats and feeding? We initiate, but do drop in EBF throughout stay.
I think I answered that question earlier too. It is just having our nurses trained to continue in postpartum. And as I said, if you're a baby-friendly hospital, that is required of all nurses to be trained to do skin to skin in postpartum, and then encouraging moms. Again, keep in mind this education, not only to nurses. Educating your moms are so important. So that education starts when she finds out she's pregnant. And that starts in the prenatal care offices when they come in for their monthly visit, and then later on bi-weekly visits. Every time they come in, those educational points need to be reinforced. And then I'm sure the OBs should be able to get them on board the importance of skin to skin. So I think that needs to be reinforced when they come in for checkup. And then it needs to be, so as a baby-friendly hospital, again, that is part of a requirement. If you're not, then, this is a good, practice to follow. So, I think it's a win-win situation for mom and baby. So keep going.
Perfect.
Yeah.
Another question, and we only have time maybe for, this may be our last question. We'll see.
No
How
problem.
long does the NAN stay with the newborn?
So the NAN, usually, so as I said, the primary nurse will receive the baby and the NAN will come in immediately the baby is delivered. And, the first 10 minutes or so to get the baby going and making sure the baby is safe. Safety is very important, especially with your C-section moms, making sure that the side rails are up, mom is okay. Provided there is a second person, a husband or a spouse or a mom, or grandma standing next to the NAN should be able to go to the next delivery and take care of, go back and forth. So that's how we train them, because we have more than one delivery happening at the time. We have 2 or 3 deliveries happening. So she should be able to manage at least 2 to 3 deliveries at a time, going back and forth. And then our vaginal deliveries stay in a little over an hour in labor and delivery, and then they go to postpartum. Once the postpartum nurse takes over, then she will continue the skin to skin, but until she's in L&D, the NAN will stay, making sure, not when I say stay, she's not completely sitting with that mom and baby. She has more than one patient. She'll be going back and forth. So it is the time until they are transferred back to postpartum. Yeah.
Okay, I think this may be our last question. Are the babies in the hypoglycemia protocol able to remain skin to skin for the first hour and breastfeed?
Absolutely. So if you have the hypoglycemia algorithm going, we use the hypoglycemia algorithm. Breastfeeding is the first thing. We also do antepartum expression of breast milk if moms are not able to express right away, but yeah, they can. So I don't think that is a contraindication unless the baby is hypoglycemic and showing signs and symptoms of hypoglycemia, like jitteriness and the baby's not well, then the baby get transferred and given glucose. But we also use glucose gel. So if the first 30 minutes the baby's skin to skin and breastfeeding, and the baby's sugar is checked up within the first hour, and that depending on that blood sugar, we make a decision on our algorithm whether the baby can continue breastfeeding or baby needs to be given glucose gel. Again, the baby doesn't have to be transferred to NICU for that. Baby can stay as long as the baby is stable. So we do not separate them for hypoglycemia unless the baby is symptomatic.
Okay, and I believe that's all we have for questions.
Okay.
We'll still gather these questions for all of you in the audience, and we can address those in follow-up afterwards. So thank you, Dr. George, and thank you everyone for attending today's webinar. One hospital took its exclusive breastfeeding rate from 50% to 83%, and you can too. Once you leave today's webinar, you'll receive a survey of the presentation, and we would appreciate if you would complete that and provide your feedback. On behalf of Medela and Dr. George, thank you so much for joining us today, and have a great rest of your afternoon. And thank you, Dr. George.
Thank you. Thank you.